Abid, how are you?
I am well, thank you. How are you?
I'm fine indeed. Right, if you want to introduce.
My name is Abid Hussain. I've been a podiatrist for 28 years for my sins. I have done a PGC and an MSc in sports medicine. I'm currently doing a PhD. I see a lot of children in clinics. So today we thought it would be a really good topic to talk about the most common things we see with children in clinic.
Okay, so yeah, because I thought we'll start a new program.
That's right.
With very rare we talk about children's feet.
That's right, yeah.
But life begins.
That's right.
The down end, and life begins from toddlers.
That's right.
And I remember many years ago, many moons ago, one of my assignment was on podopediatric. By the way, what is podopediatrics?
It's a good question. Podopediatrics, we're basically looking at how children walk. So we're interested in how they're walking and if there's any complaints or any pain or any concerns that the parents may have regarding how they walk.
Okay, so it's more to do with the gait, we
That's
call
right,
it.
yeah.
The gait and the from the toddlers.
That's right, yes.
To teenage. We'll talk about that range. Yes. Also, especially amongst Asian community, there are a lot of myth about, isn't it?
There is. I mean, look, with children, especially in the Asian community and the Afro-Caribbean community, we have certain traits within our communities regarding our foot structures. So people get concerned.
So basically,
at a young age.
As I said, currently we're talking about podopediatric, which is picture one more or less. We'll show on the what we mean by podopediatric on a subject of picture one. So I'll say it on that. Like as I said, within our community,
that's right.
There are huge myths and there are concerns as well.
Yes, sir.
I passionately believe that we should educate the community.
I spend more time educating parents than I do with doing any interventions for for the children. I think it's really important for us podiatrists and other health colleagues to really speak to the parents and to reassure the parents. These parents tend to be parents that this is their first child, which is why they're concerned, and I don't blame them. But we should spend a lot of time speaking to the parents.
So you've been in practice for a long time, haven't you?
That's right. Yes.
Right. Yeah. So is there anything we do in the practice which other podiatrists don't touch?
I tend to do interventions and I tend to use techniques that are out of the box. And I tend to explore different avenues that could be controversial, as long as I have the parents' consent and as long as we do no harm, essentially.
Concerning about how do we recognize or how do we assess or find the problem of the podopediatric or children problem?
I think this is picture two, isn't it?
Yeah, picture two.
First of all, I mean, before we talk about how we assess, I think it would be a good thing to talk about what are the most common things we see in clinic.
Absolutely.
Because obviously we would have assessed differently depending on what we see in clinic. So most commonly, what we see is parents bringing children to us with flat feet. So they say that my child has flat feet, and that could be anything from 6 months old all the way up to 9-10 years old. And there are other conditions, obviously. So sometimes the child's walking in, sometimes they're walking on their tiptoes. The first thing I do when it comes to assessment is not even touch the child. First, I talk to the parents. I want to know about the child's birth, the mother's pregnancy. Was there any complications during the pregnancy? Did the pregnancy go full term? Was there any developmental concerns? Did the child meet all the milestones? Which is really important, because if there was a delayed milestones, they may give you hints towards certain things. I want to know about the family. Is there something on the mother's side or the father's side that is prevalent? That would really give us clues before we touch the child. I also want to know about, is the child falling and tripping when they're playing? Are they complaining of pain in their feet and their legs. Now, children don't say it hurts. They might cry a lot. They might rub a certain part of their foot or their leg. They might say it hurts. It depends on what age they are. So I'm trying to get these hints from the parents. So
you are collecting a lot of information.
I'm doing a Sherlock Holmes.
Yes.
I'm at that stage.
Like as I say, right? Consultation, right? 80% of any medical problem is on good consultation.
It's a good history taking. I mean, I might even ask, when the child sits and watches TV, do they sit in like a W position, which gives you certain hints about femoral anteversion? Basically, is their legs too twisted in? But we're going to get to that later on. So we do. That's the first thing we do, and then we look at the patient. The patient or the child, right? Walking. We look at their walking. We look at them walking on their tiptoes, on their heels. And then we'll do other tests while they're lying down.
Does arch form?
So this, I think, is picture 3.
Picture 3.
So I mean, often parents bring their children and their toddlers, and they don't have an arch. And I'm always telling them, look, the child's arch isn't going to be formed when they're 6 months old. It can usually, you can start to begin to see an arch when they're about 4 years old. They get a developmental arch. It can take up to 10 years old. So sometimes a child could be flat-footed for a little while, but as they get older, as they lose some of the fat, because they could have a lot of visceral fat when they're young, ligament laxity, they will, as that develops, they will develop an arch. So it's natural for a child not to have an arch. Sometimes, very rarely, I have seen young children, babies that have a high arch deformity because they have a genetic factor in their family to say that they have a high arch deformity. That's quite rare.
It takes at least 6-7 years before actually the arch or bone started to appear, and it's not important on that aspect because they're developing.
I'm always telling parents, don't worry about it. Unless there's a problem, we just want to keep an eye on it.
Yeah, because it's eventually is going to develop the arch, because as the bone also is slowly will grow, form the arch itself, right? So therefore, it will take time, and once a child is born, there's no arch anyway. It's nice.
It's
flat,
supple,
it's simple, flat. It's not even a flat foot. It's just a lot of masses of tissue, isn't it?
That's right.
What is flexible flat foot?
This is probably the most common thing we see in clinic. This could be a child when they are now walking, so they're 3 or 4 years old, maybe even older, and they have a flat foot, and the parent's quite concerned. But when you ask the child to go up on their tiptoes, the arch forms. This is something that we don't.
So it's not a totally flat foot.
It's not a flat foot. Well, it's a flexible flat foot.
Flexible. Because once they do toe in like that, you can see the curvature of the arch.
In fact, a parent can do a very simple test. If you ask the child to stand in front of you, if you raise the big toe and the arch forms, that means it's a flexible flat foot. We don't need to do anything for this. We just need to keep an eye on it. However, if the child's complaining of discomfort and pain, then we may give something like an insole, but a very soft insole. But I'm very reluctant to do that unless the child's in pain, discomfort.
Yeah, but there are many theories on that aspect, right? Some, especially in the medical profession. As a podiatrist, when we put podiatrists a hat on, it's a different world altogether. But some medical professionals think certain thing will go away. Yes, I do understand, but remember, sometimes we also have to think outside of the box, don't we?
We do. I mean, look, we know from the evidence that usually it just does get better on its own. But there are a handful of patients where it doesn't. And if the child's in discomfort, and if it's stopping them from doing PE or playing with their friends, and if it's giving them discomfort, then we may do something about it. And that might not just be orthotics. It might be footwear advice as well.
Or even exercise.
Exercises. At certain ages, I give different exercises. So yeah, it may be.
We talk about flexible flat foot, right? There's another thing called rigid. So it's picture 5, right? Rigid flat foot. most commonly known as calcaneal navicular and talar calcaneal.
Yeah. Coalitions.
Coalition.
So there's a few different.
Usually between 10 to 15 years old.
That's right. Yes.
Right. So what can you just?
So first of all, these are children that I see in the first decade of their life. They tend to be 10, 11, 12, 13 years old. They'll have a flat foot. They could have a rigid flat foot. That means there's a couple of different reasons. So they can have a tarsal coalition. So there should be a space between all the bones in the foot. Sometimes that space can get narrower and narrower to the point where there's not much movement. When that happens, it can be quite uncomfortable and the arch collapses. You can also have an accessory bone, ossicle, accessory navicular is called. That can lead to it also. And there's a couple of other causes that like I'm not going to go into detail right now. This can really affect the child's well-being, and we tend to take this a lot more seriously. So I tend to give a lot of these children exercises, orthotics. They tend to be firmer orthotics, quite hard, and comfortable at the same time, so we try and give a soft top cover as well. But there are surgical options for these. I'm very reluctant to refer any child for surgery. I think in certain parts of the world surgery is more prevalent, but in the UK we tend not to do any surgery for children. It's more about education for the parents. It's more about the footwear education, orthotics, exercises, but it's also about keeping an eye on it. If you know what it is, you can keep an eye on it and you can see how it's going to proceed. The way we diagnose this is these are children that when they go up on their tiptoes, an arch is not formed, and when we palpate the foot, we can tell there's the range of motion is not quite right. But we need to have an X-ray done, which soon we will both have in our clinics, by the way.
That's our next investment.
That's right.
Yeah.
But an X-ray is essential to diagnose it. But a rigid flat foot deformity can affect about 5 to 10% of children, so it is quite common.
Yeah, but then you got Achilles tendon spasticity.
Yeah.
What is that?
Okay, it's more rarer. So this is when the Achilles tendon, which is at the back of the heel, and the calf is very, very tight. So this can either result in the child walking on their tiptoes, or it can result in a deformity of that could lead to flat feet. Now, what I'm just thinking about right now is this child will also get pain at the outside of the foot, not just on the inside, because all the tendons on the outside of the foot are being stretched and worked so hard. So all the peroneal tendons are really working really hard. So the child might say, I'm getting a lot of pain on the outside of my foot. And you're thinking, well, you've got flat feet, you should have it on the inside. It's because those structures are working really hard. So we need to keep an eye on that as well.
Right. That is basically this bone, is it?
The extra bone, yeah.
Extra bone. Extra bone, I've seen quite common.
Yeah, it is common. It is very common, actually.
It's quite common.
Yeah.
I've seen many children.
Yeah, it can be very painful. There'll be a sore spot right on the inside of the foot where you need to make a special insole just with a little bit of padding, just to gently lift it up. But it has to be exactly on the spot. But yeah, it is common.
Before I go to hips, you never told me about my daughter.
Oh yes, congratulations.
Yeah.
Mr. Mia's daughter is now a podiatrist.
Well,
so I'm hoping he can retire now and sit down and not do much work while his daughter takes over his practice.
Well, I'm glad. Not only that, there was 2 of the Bengali girl, and remember you met one out from Pakistani background.
Yeah.
So I'm so glad that there are a lot of Asians now coming into
from the ethnic
podiatry, medical and surgical field. So inshallah one day they'll become a surgeon or podopediatric, or another is you done sports medicine yourself, so you love sports medicine.
That's right. I see mainly athletes.
You're doing PhD currently on sports medicine.
That's right. Yes.
And how is PhD?
It's taken up a lot more time than I thought it would.
Have you lost the weight a bit?
I've lost some black hair. It's becoming whiter, so from the stress of doing the PhD. But no, it's good. I'm enjoying it.
So how long to go then?
Many years.
God knows.
Another 5 years.
Oh, but
so So by the time I finished my PhD, my son would have become a podiatrist and done something else. So
yeah, because as I said, I was so glad and shocked that he is following the dad's footstep.
Yeah.
And hopefully,
you wasn't the only one that was shocked, by the way. But yes.
Yeah, I know the family. But hopefully, inshallah, one day our children will grow to be the best
Inshallah.
practitioner in the field.
Inshallah.
And they will bring new things.
That's right.
New treatment modality, new evidence-based medicine.
That's right.
Right? And they can go back to Apna countries, like you're from Pakistan background, we're from Bangladeshi background, so Indian subcontinent, they can take their knowledge.
That's right.
There and, if they, it's up to them.
That's right.
We don't know.
Yeah.
Now, let's get back to podopediatric.
Okay.
Right. Why do we need to look into
Hips.
hips?
It's a good question. But I think
Picture number 6.
I think it's worthwhile. Let's go back to the assessment.
Yes,
so
please.
When we spoke about the assessment, I spoke about how we were going to speak to the parents and find the history. We're going to watch the child walk, and we're going to feel the child's feet, make them walk on their tiptoes. We're also going to see how flexible they are. Have they got flexible fingers, wrists, elbows? Can they touch the floor with the backs of their hands? So we're going to be looking at their flexibility score. One of the things that's connected to that is their hips. It's very important that we assess their hips. So with hips, we're looking at if they've got too much range of motion. So I normally ask the parents to put the child flat on their stomach, and I'm pushing the legs out. If I see the child's feet touching the
Floor.
table, the actual table, then they have a lot of internal rotation, and that can lead to certain problems. So we're looking at hips, but we're also looking at the lower leg as well. So we do something called the foot-thigh angle. So we're looking at if there's too much rotation up here, or if there's too much rotation here, that can lead to a change in the way a child walks. So there might be nothing wrong with the feet at all. The problem might be further up here or here. So
you mean fibia or tibula bone?
Yeah, in the femur or the tibia. So we're looking at femoral anteversion and tibial internal torsion. Now, even if they have that, we're still not necessarily going to do anything, because the child will grow out of it. They tend to grow out of it, but we want to keep an eye on it. We want to make sure that they don't have any hip problem. They don't have any ankle problem, because they can also hurt the ankle. To be honest, we're looking for big red flags. We're looking for
what is the red flag then?
So we're looking at things that
red flag basically mean danger.
Yeah, so we're looking at certain conditions that need a intervention, like if there's an infection further up in the hips, or if there's hip dysplasia, if there's other things that we want to take into consideration, then we're looking at those. And there's other developmental milestones, conditions, not milestones. So there's one called Ehlers-Danlos syndrome, which means the child's too flexible.
Yeah, very
too flexible.
Yeah.
One of the other things we're looking at is Marfan syndrome. Occurs a lot in boys. They have flat feet, but they tend to have long fingers, and other characteristics as well, high cleft. So we're looking at certain conditions that we think, okay, we might need to keep an eye on this. But if you can imagine a child, it's in a womb, it's all bound up. Now, sometimes it's bound up for 9 months. Now, not every child unwinds at the same rate. So some children will
grow out of the problem
very quickly, and others will take some time. We only, as I'm going to reiterate over and over again, we only really take it seriously when the child's in a lot of discomfort and pain. Then we really take it seriously. Could be that the child has sensory issues. So you need to think really outside the box, because normally by the time the parents come to us, they've been to the NHS podiatrist, and NHS podiatrists, bless them, they will say leave it, they will grow out of it. What happens if they don't grow out of it? What do we start doing then?
That's sorry to budge you on that. My concern as a private practitioner is they go to the NHS, like I said, lovely, our colleagues are, they are well expert expert in the
That's
field,
right, yeah.
but they also have the limitation, right? They see thousands of patients, and they put priority on certain things as well, right? But when parents are so concerned, they come in a private sector, they come with the child to see me. They expect something more, don't they?
No, and we want to give them something more because they're concerned. So first of all, it is a lot about reassuring parents, and that I do a lot of. Then it's about thinking outside the box. So giving orthotics, maybe with the heel raised, that will encourage
Have you heard
them.
of DAFO?
Yeah, giving the
dynamic ankle foot, yeah.
So sometimes that can help. Sometimes strategies like getting the child to walk on different surfaces, maybe grass, barefooted, maybe jelly-like surfaces, maybe. Sometimes you'll find that when the child goes to like those bouncy inflatable world, their foot actually goes flatter, and they feel they start walking with a flatter foot. Sometimes you have to start thinking way outside the box, and I can be quite controversial, as some of my colleagues know. So I might use like a Prism glasses, and if they
that's something. By the way, controversial. What is called Prism
glasses. So I'm looking at this is a diagnostic aid. It's not necessarily you're going to put these children in Prism glasses forever. But if your child puts on these Prism glasses and their feet go on the floor for 5 or 10 seconds, then I know that it's not that the child has anything wrong with their foot. It's their perception of their space around them. So in that case, maybe an optician referral can help. But sometimes it can be very difficult. When they get into adulthood, so if they're still doing it into adulthood, you can actually do Botox injections.
Yeah, which
with the calf, which
too.
can help to decrease the tightness, but it is very difficult.
With the Prism
glasses,
there's a few of our colleagues a bit worried on that, isn't it? Or are they? Is just
they were just
hearsay.
concerned about anything that is outside the box.
Okay, so they're not inside the box.
They're
inside the box.
I don't
they're
think
not
they've even seen the box.
Okay, so there you go. Some of them are too busy, or they don't see beyond. Then that's it's a naive way to say it. It's like they're comfortable within their comfort zone.
Yeah, I mean, look, it's so essentially we all believe in empirical evidence. Now, evidence-based medicine isn't just
evidence.
studies.
It's clinical.
It's clinical, and it's about patient perception. So it's that it's all three things put together. So it's about trying different things
for different group of people, different outcome, and no harm if it's there. As long as you do no harm, and no need to be, because I don't want to use that word narrow. No need to be broad-minded. That's the word, right? Even my colleagues who's watching it, be broad-minded. No harm in it. And there are others who thinks beyond your concept as well. It's a freedom, information of freedom, knowledge. Knowledge also have different. If nobody will think your way, there are other ways as well. It's not my way or highway. If you think something like that, my colleagues or any medical profession, then it's conflict of interest, isn't it? It's a danger zone, right? It can be danger zone. Another thing, right, with toe walking is idiopathic.
Yeah.
What does that mean, idiopathic?
There's no real reason for
it. Idiopathic means no reason nai. Anna reason toe working.
So a lot of children grow out of it.
Yeah,
a lot of children do grow out of it. It's and I think parents can be overly concerned, but some children don't.
No.
But you can. I mean, as I said, you can do some strategies to
and the potential problem with toe walking can be foot pain.
Yeah.
Can be muscular contraction, which you explained about Botox injection, right? Widening of foot as well, and also poor alignment. Can you explain me what we mean plain English poor alignment?
So if the child's got walking on their tiptoes, then not just that they're walking on their tiptoes, they are changing their alignment in their pelvis to be able to walk on their tiptoes. So they're going to be changing their posture. That could have long-term implications. One of the other things that I forgot to mention, because we're talking about alignment, is we also look at the child's spine. So we're looking at if they've got any scoliosis, if there's any issues around the spine. So most podiatrists that see a lot of children, we will also be looking at the child's spine also.
Yes, because it's for me, right? I don't know how you. For me on biomechanic, when I assess biomechanic, by the way, I do head to toe. Right, I look from the head all the way down to the toe, because it's I look at the holistic side of the. Although we specialize on the lower limb, but I do believe that foundation. You have to go slowly and see the whole way the child.
The entire kinetic chain. Yeah.
Absolutely, kinetic change. And you did mention about foot and ankle orthosis as well. DAFO we mentioned. What about the another common, possibly same interlinked toe walking, pigeon toe?
Pigeon toe. So pigeon toe is when the child walks inwards, inward toeing, often called pigeon toeing.
Is it anything related with the pigeon?
No, nothing related to pigeon.
There you go.
This is generally caused because of two reasons. Actually, it could be three reasons. It could be from the femoral anteversion. It could be twisting of the thigh bone. Most commonly, it's the lower leg bone is twisted in, internal tibial torsion. And then there's a condition where the foot is called metatarsus adductus, where the bones in the front of the foot are facing inwards.
Yes, because actually I've got pictures. By the way, this is foot and lower limb problem in children I made donkeys years ago.
Wonderful.
Right, and you talked everything on there about. You just touched on metatarsus abductus deformity. I've lately seen a couple of bow leg. Another thing. Let's talk about bow leg.
Yeah.
Right.
So bow legs, so the two things that can happen is you can get knock knees or bow legs.
Yeah, knock knees. I don't know whether they can see in the pictures.
Now, it's something we don't do anything about, really. We just keep an eye on it. It's a natural thing for a child to have. However, we do know that if the child has bow legs or knock knees, it could put certain pressures on the foot and ankle, and so we're aware of that, but not necessarily we're not necessarily going to do any surgical interventions for bow legs or knock knees.
So a child gait can cause concern if it's not the correct gait pattern.
It can cause concern to the parent,
yes,
more than anything else, and it's a child. So when we define children, when we're looking at 4 or 5-year-olds, I'm looking at a 4 or 5-year-old completely differently to how I'm looking to it as an adolescent. Someone that's playing a lot of football, someone that's doing a lot of other things, and then they're having discomfort in their lower limb, that we might do a lot more interventions with. But the child gait pattern can cause concern, yes.
And what would be, putting aside of podiatrist hat on, what would you think the most important thing if a parent have a concern? Should they seek a podiatrist? As you know, most of the podiatrists are specialists in podopediatrics. Some of them can go expand. See, knowledge has no end. Specialism in any medical profession is endless, right? So do you think it would be wise enough for parent to see any podiatrist near their home?
So first of all, I think definitely it is wiser for parents to seek advice from a podiatrist. Most parents don't actually go to a podiatrist first. They tend to go to the GP. and they may get really good advice from the GP. But if they can find a podiatrist that sees a lot of biomechanics, there are some of my colleagues that do a lot of routine podiatry that might not see a lot of children, might not be as proficient, or might not have enough experience to have a look at the child. But most podiatrists that do a lot of sports medicine or biomechanics,
it's interlinked, isn't it?
Interlinked, yeah. It's very much interlinked. So I see a lot of children. I see a lot of young children.
So your strong advice would be for the parent to take the child to the podiatrist for at least for assessment, because
that's right, yeah.
If you in a dental profession, they advocate every year, every 6 months, every year, 2 times they should see a.
I've been saying this a long time that I think we need to get this education into the public, where we seek a yearly dental check. We should have a yearly foot check, and I think that should be a routine thing. Everybody should visit a podiatrist, check their skin, check their nails, check how they're walking, do these kind of checks. And if there's any complaints, obviously you can address it at that stage. But with children, I think it's wise. I have had some parents that have just brought the child in with no problems just to get a checkup, and I like that. I like when parents do that, because it puts the parents' mind at ease. It puts I know a lot more then, because I've taken a good record. So if I do see the child later on in life, I've got a record of what they were like before.
Yeah, as I said, recently I seen a case. A parent seen the GP, but like as usual, they haven't seen the GP. It's nowadays what you call the telephone consultation. So how would the GP assess? So they send a picture, right? And it is metatarso adductus, right? So I personally believe, that's my, like as I said, you know me, I always think outside the box. I personally think that child could have been at least assurance with the parent with the serial cast, right? But unfortunately nothing. But I know, I'm a parent myself, the parent are concerned.
Yeah.
So they came to me, they were looking for something, like as I said, when they come to private sector, they're looking for extra mile, right? So more or less assurance. So when they came, I've looked at the child, I took the medical history, I looked at what the NHS done or who they went. Somehow he wasn't referred to Podopediatric or to pediatrician to assess the child. So basically I reassured them with brace, simple brace. I said, look, you can go to the internet, get this, and apparently parents were happy on that. Because most possibility that this will be slowly correct itself, isn't it?
In some cases.
In some cases, yeah. So the most important, I assured the patient what they can do, they can find. They were happy with that.
I mean, we see, like, for example, we have a lot of parents that bring their children to us with heel pain.
Yeah, I was about to talk to you about heel pain, because I like that subject, heel pain.
I mean, it's something I see a lot of. So it's called traction apophysitis or Sever's disease, which I hate using the word Sever's disease because it's not really a disease.
It's a condition.
It's a condition. So as the child is getting older, the bones are not fused. So the bones are when you look at the ultrasound, it looks like they've got 2 bones there.
Yes.
So the Achilles tendon that goes into the back of the bone, the heel, is getting irritated, and these are normally young boys that play loads of football or rugby. And I've recently had a child who was in an academy for a championship club, and with high hopes as well, who's getting this particular condition. So we see this a lot, and unfortunately, this can be poorly managed by our physiotherapy colleagues, where they give them exercises at the end of a step. Don't do exercises at the end of a step. If your child has this, it's a bad choice. In fact, I tend not to do much stretching with this. So class 4 laser can really help, and we do class 4 laser. Giving orthotics, we give insoles with a bit of a heel raise, and just a lot of patient education and parent education with this. It can take some time to heal. Sometimes it can heal in a couple of months. I've known it to drag on for 18 months sometimes, which can be not good for the child or the parent. So it is something that we see a lot of. I see a lot of it in the heel. Sometimes I see it in the knee. Sometimes.
Okay, what there's a word for that? Oscars.
So there's two.
That's it.
So
okay.
let me tell you about the two.
One more, important. Layman language is growing pain, isn't it?
Yeah, growing pain.
Okay, our colleague explain korbo kisu.
So these are older children. These are 13, 14, 15-year-old children. They also tend to be really active.
We talked about toddlers a lot. I'm not basically sure toddlers. Toddlers basically 5, 6. We talked about more or less today.
So now we're going up. Now we're going
toddlers
to 13.
3 child fast
So now we're going to the 13, 14, 15-year-old.
Growing children.
The growing children, and they're going through growth spurts and puberty, and they're getting pains. Now, so the two conditions that can affect the knee, one is called, this is a long name, Singding-Larsen-Johansson syndrome.
What's now?
It's basically at the top of the knee here, the patella tendon is being stretched. The one at the bottom is called Osgood-Schindler's disease, also a long name.
It's a gentleman. Is it founded by that chap?
Yeah, it's been founded by these gentlemen. So we do an ultrasound scan. Both me and Mr. Mayor do an ultrasound, and it comes up quite beautifully on ultrasound scan.
It's the bulginess.
Yeah, it's the bulging either at the tibial tuberosity or just at the inferior portion of the patella. Now, we manage this sometimes with orthotics, but a lot of time with custom exercises that we might do to try and alleviate the pain.
Okay, we are more or less now coming to the end of our program, and hopefully you enjoyed our program.